Hello everyone, my name is Jayanti Rai. I'm an advanced physiotherapy practitioner working at Kent Community Health NHS Foundation Trust. A huge thank you to OR UK for giving me this opportunity to present the frozen shoulder evidence-based rehabilitation. Few facts about the frozen shoulder. It's idiopathic. Approximately 9% of people are affected, aged between 25 to 64 years. Severe pain lasting 3 to 9 months, followed by increasing stiffness of 4 to 12 months. After this condition usually improves, 20% of the patient develop same problem in other shoulder, and 30% of the patients with the diabetes develop frozen shoulder. The average duration of symptom is 30 months, and at 52 months follow-up, 6% had severe symptoms. So full resolution of symptoms does not always occur. Best NBOA patient care pathway was published in 2015, and they described frozen shoulder as painful and debilitating condition leading to stiffness and disability. Active and passive external rotation of the affected shoulder is limited. Radiographs are necessary to exclude osteoarthritis. Exact cause is unknown. When it comes to the interventions, there's a lot of uncertainties, and anything starting from the non-steroidal anti-inflammatory drugs can be used with the increasing invasiveness, including corticosteroid injections, oral corticosteroids, physiotherapy, hydrodilatation, manipulation under anesthetic, arthroscopy capsular release. However, there is no evidence of significant benefit in the long term with these interventions. So if you look at the clinical effectiveness of non-surgical interventions, there is substantial gap or no or insufficient evidence for physical therapy. But let's not forget that evidence-based practice is not only about the research evidence, but also about the clinical experience and patient preferences. A study done on frozen shoulder patients in Australia on 5 patients before and after anesthetic revealed that passive range of motion of abduction, there was a minimal improvement of 55 degree and maximal improvement of 110 degree. External rotation range improved between 15 and 40 degree, and this explained that part of the stiffness could be due to the active muscle guarding and not capsular contracture as a major factor to movement restrictions. And we should be aware of that in our treatment. A qualitative study of patients' perception and priorities when living with a primary shoulder revealed that patient identified their priorities as regaining function. So they were not looking to improve the movement but regaining their day-to-day activities, early diagnosis, raising awareness among healthcare staff on diagnosis, and they wanted more information. So we can learn a lot and gain insight into how it is to live with the frozen shoulder. Goals of rehabilitation. Patient education should be an important part of our physiotherapy program in the frozen shoulder rehabilitation. We must give answer to the questions to the patients, like for example, what is happening to my shoulder? Why is it happening? How long it will take to get better? And what options we have. We can also reduce the fear avoidance by answering their questions, reinforce the confidence in the future with regards to good outcome, motivate the patients to keep moving the shoulder and the full body, and finally muscle strengthening of the rotator cuff and periscapular muscles, moving forward with the functional progressions and increasing the power and endurance. Here I'm sharing the information from UK Frost trial, which is the largest trial to date, comparing 3 common interventions delivered in the healthcare for frozen shoulder. So in this study, the patients were randomized into 3 groups. One was manipulation under anesthetic, followed with a steroid injection. Second one was arthroscopic capsular release with a steroid injection. And third group had early structured physiotherapy followed by steroid injection. All the groups had 6 to 12 sessions of physiotherapy following the intervention. The study team compared the clinical effectiveness and cost effectiveness. They also interviewed the clinicians and the participants to understand their experience in participating in the research. The study team published their results and mentioned that all the 3 treatments lead to significant improvement over 12 months. None were clearly superior. Patients with the diabetes had worse outcomes. Early structured physiotherapy plus steroid injection was the only non-surgical treatment. Steroid injection followed by physiotherapy can be provided early, but patients were more likely to require further treatment. Arthroscopic capsular release is associated with the higher costs and risks. Manipulation under anesthetic was the most cost-effective treatment. So the key message from this trial was that early structured physiotherapy plus steroid injection is an effective intervention. Steroid injection followed by physiotherapy can be provided early to improve the patient's outcomes. So this is the physiotherapy protocol from the UK Frost. Even though it was developed for secondary care, it can be applied in any healthcare setting. They explained the best way to diagnose the stages of the frozen shoulder is by asking the patient which of the following is their main problem today or the day they present in the clinic. If the patient tells pain is more than the stiffness, then they are in the pain predominant stage. If the patient tells the pain and stiffness are equal, then patient is still in the pain predominant stage. If patient complains that stiffness is their main problem, then they are in the stiffness predominant stage. These phases will overlap with a varying degree, and treatment should be modified to each patient's needs. In the pain predominant stage, it's must to give advice and education to our patients. Manual shoulder mobilization is important. Home exercises should be given with the instructions and reviewed regularly. Other treatment can be given as a complementary or supplementary. They include acupuncture, TENS, trigger point therapy, hydrotherapy, posture correction, relaxation, manual therapy to cervical and thoracic spine, heat and supervised exercises. Brace, cranial therapy, deep friction, and laser were not allowed because there was no evidence for it. Bowen therapy, shockwave therapy, and ultrasound therapy were discouraged, again due to a lack of evidence. So we know from the studies that in pain predominant stage, exercises should be done within the pain range. Painful treatment does not result in superior outcome. No indication for manual therapy beyond pain limit. Exercise therapy and manual therapy within pain range results in good treatment program. It's very important to tell our patients in the pain predominant stage that they have got to maintain their general fitness and improve the whole body mobility. Even though they have got shoulder pain, this will help to increase their fitness and reduce the pain by distraction. National Institute for Health and Care Excellence recommends approximately 150 minutes of moderate intensity exercises or 75 minutes of vigorous intensity exercises in a week for an adult over the age of 18 years. These can include running, climbing stairs, any form of sports like swimming, brisk walking, or cycling. Other exercises can be done in the pain predominant stage are the pendular exercises, making sure that you're moving your arm like a pendulum with the use of the body's momentum in forward and backwards, sideways, and then making a circle in a clockwise and anti-clockwise directions. The gravity will take the weight of the arm, and this will help in increasing the movement. Stick exercises are another example. They're called assisted exercises, and again, they can be done in the flexion, abduction to increase range of movement. Distraction is a very useful technique in the pain predominant stage. It helps to reduce the fear avoidance. It reduces the negative pain-related cognitions. And we know that studies in children and people with the mental health disease, music and virtual reality can help as well by way of distraction. So here just the patient is using a ball. The focus is the starting from as low as they can and then try to increase the bouncing height and then moving across the body. This will help them to take their mind off the shoulder and they'll be focusing on the ball. So just one example of how a home equipment can be used to distract the patient to improve the mobility and range of motion. So these are the home exercises which can be given to the patients to improve their mobility within the pain range. Starting from the easy movements like shoulder shrugs with the arms supported on the thighs, doing sternal lift, watching their posture throughout the day, and doing supported thigh flexion and extension by putting their hands on the thigh and sliding into flexion and extension, moving into pendular exercises with the support, and then doing supported flexion with the help of a towel, just moving away from the couch or a table at home or away from the bed. In the stiffness predominant stage, it is must to give advice and education. Manual shoulder mobilization is helpful. Home exercises should be given with the instructions and reviewed regularly. Supervised exercises should be given and we should be function based. And the exercises can be done at the end range of all the planes. Other complementary therapies could be used, including hydrotherapy, posture correction, soft tissue techniques, manual therapy for cervical and thoracic spine, supervised exercises. However, the evidence was weak in the stiffness stage. Brace, craniosacral therapy, deep friction, laser, interferential therapy, and shockwave therapy were not allowed due to the weak evidence. And Bowen therapy, shockwave therapy, ultrasound therapy, mirror therapy, and shockwave diathermy were discouraged. In the stiffness predominant stage, the home exercises can be given. The key thing to watch is that stretching at the end of a range in all plane is given. The easiest way to do is start in the supine line or sitting and do a gentle sustained stretches by comparing the contralateral side or using the sticks. Taking the hand behind the head, doing external rotation with the wall support, and stretching the posterior capsule in supine and sideline can help to improve the range of movement. Strength training can be incorporated in the stiffness predominant stage. Effect of strengthening rotator cuff in frozen shoulder is described in a randomized controlled trial by Rawat et al. In 2017. They compared the 42 patients with the diagnosis of frozen shoulder. One group received TENS and joint mobilization, and strengthening exercises was added to the another group. Adding structured strengthening program resulted in improvement in pain, range of motion, and in function. So there are good results with the strengthening exercises, and it's important to incorporate them as the patient can tolerate. In summary, the etiology for frozen shoulder is unclear. Rehabilitation is done in two phases, pain predominant and stiffness predominant phase. Patient education and advice forms an important part of management. In pain predominant stage, exercises are done within the pain range. In stiffness predominant stage, exercises are done at the end of the range of movement available in all planes. And steroid injections can help to reduce the pain and improve the compliance with the rehabilitation. Rehabilitation following manipulation under anesthesia or arthroscopic capsular release, it's very important to document the patient's range of motion before and after the procedure. In manipulation under anesthetic, it's usually a day case surgery. Patients are given general anesthetic, nerve block is applied, and steroid injection is given intraoperatively sometimes to improve the pain relief. So as I mentioned, document the range of motion achieved under anesthetic and follow it in the 6 weeks to ensure that the range of motion is same which was achieved under anesthetic. No slings are required, and physiotherapy can be started and must start within the 24 hours time, and exercises must be performed hourly basis in all directions. There are no restrictions with regards to range of motion. Activities of daily life can be started as soon as possible. Return to work and sports as the patient is able to tolerate. When it comes to arthroscopic capsular release, again it's a day case surgery done under general anesthetic, nerve block is applied, and sometimes steroid injection is given for a pain relief. Document the range of motion which has been achieved under anesthetic and ensure it's achieved within the 6 weeks time. Sling can be worn for comfort only for a few hours or a day. Exercises must start within 24 hours time in all direction and must be done in hourly basis. There are no restrictions for range of motion activities. Activities of daily living can be started as soon as possible. Return to sports and work as patient is able to. I want to say a massive thank you for watching this webinar and thanks to the organizers.